Hi friends, welcome to Interactive Medicine. In this section, we are going to discuss the second chapter of pharmacology, that is the pharmacology of nervous system. Learn anatomy and physiology here, guys. We are going to discuss about classification, definitions, neurotransmitters, drugs acting on CNS, CNS depressants, CNS stimulants, miscellaneous, drugs acting on peripheral nervous system, sympathetic nervous system, parasympathetic nervous system, adrenergic, anti-adrenergic, cholinergic, and anticholinergic drugs. Nervous system is divided into central nervous system and peripheral nervous system. CNS include the brain and the spinal cord, and the PNS include the efferent division and the afferent division. Efferent division include autonomic nervous system or ANS, then somatic nervous system or SNS, which include skeletal muscle, that is motor, and autonomic nervous system divides into sympathetic, parasympathetic, enteric. Afferent division, it includes nerves, and nerves can be present in smooth muscles and glands, and also skeletal muscles, which gives sensory. The central nervous system pharmacology. Just rewind your memory. The brain, which include the cerebrum, cerebellum, pons, medulla oblongata, and the spinal cord, which have the cervical roots, dorsal roots, lumbar roots, and sacral roots, and the cerebrum, which have 5 lobes. The structural and functional unit of nervous system is neurons. Around 10 billion neurons can be present in our brain, and the parts of our neuron is dendrite, cell body, which include nucleus, and it has axon, myelin sheath, node of Ranvier, and axon terminals. Neurotransmitters are chemical substances carry messages from one neuron to another or from a neuron to body tissues, example skeletal muscles. Synapse is a small gap separating neurons. You can see on the right side picture, and we have a presynaptic neuron and postsynaptic neuron, and the cleft present between these neurons is known as synapse, and the receptors are present on the postsynaptic neuron, which are macromolecules, and they are made up of lipoprotein in nature, situated on or inside the cell membrane, having recognition properties, which recognize the chemical messengers secreted from the presynaptic neuron. And if you see the picture on the right side, you can see the nerve impulses comes from the presynaptic neuron, and we have the synaptic vesicles. The synaptic vesicle is bind to the presynaptic membrane. This process known as exocytosis and the releasing of neurotransmitters. You can see this is achieved by the influx of calcium 2 plus channel, and the neurotransmitters now present in the synaptic cleft. Then finally it gets binded with the postsynaptic membrane receptors. Then final action potential final action potential transmit through the postsynaptic neuron. Presynaptic membrane or element, then action potential, then activates calcium 2 plus ion channel, then the releasing of neurotransmitters, then released in synaptic cleft, then postsynaptic membrane, or the acetylcholine's bind with receptors or ion channels, then exert the action. This is the mechanism in the typical synaptic connection. Neurotransmitters in CNS. There is 7 type of neurotransmitters are present based on their structure. Amino acids, monoamides, peptides, nitric oxide, endocannabinoids, histamine, tachykinins. Amino acids include acetylcholine, GABA, glutamate, glycine. Monoamines include norepinephrine, dopamine, serotonin. Peptides include opioids, neurotensin, substance P, somatostatin, and neuropeptide. Drugs acting on CNS. Mainly two groups, CNS depressants and CNS stimulants, which is also known as neuroleptics. CNS depressants include sedatives, hypnotics, narcotics, and generalized arousal drugs. Sedatives, diazepam, oxazepam, etc. Hypnotics, clobazepam, nitrazepam, etc. Narcotics include morphine, codeine, etc. GA includes barbiturates, halothane, etc. CNS stimulants directly acting on CNS, reflexively acting on CNS. Directly acting on CNS, which include cortical, medullary, spinal. In cortical, we have caffeine, aminophylline, amphetamine, ephedrine, etc. Medullary, we have picrotoxin, adrenaline, nicotinamide, etc. Spinal, we have strychnine, brucine. Then reflexively acting on CNS, we have nicotine, lobetin, etc. And drugs acting on CNS: psychedelics, sedatives, hypnotics, tranquilizers, antipsychotics, anesthetics, antidepressants, antiemetics, and emetics. And anxiolytics, barbiturates, Parkinson disease drugs, CNS stimulants, benzodiazepines, anticonvulsants, dopamine antagonists, cholinergic and anticholinergic drugs. CNS depressants, anxiolytics, and sedative-hypnotics. Sedatives or anxiolytic. These are anxiolytic drugs, reduce anxiety, excitement, nervousness, irritability, exert calming effect, mild depression of CNS. Don't cause sleep, little or no effect on motor or mental functions. Hypnotics depress CNS to the point that they cause normal sleep. CNS depressants, anxiolytic and sedative hypnotics. So, non-benzodiazepine sedative hypnotic drugs. If these drugs we prescribe in lower dose, it acts as a sedative drugs. If these drugs prescribed in higher dose, then they act as hypnotics. That's why they called as dose dependent depression of CNS. Progressive depression of CNS include sedation, then hypnosis, then narcosis, then coma, then generalized arousal, then death. Classification: sedative hypnotics. It includes benzodiazepines, barbiturates, then newer agents or non-benzodiazepines. Sedative hypnotics, benzodiazepines. Classification: short acting, intermediate acting, long acting. Short acting have half-life less than 5 hours. Intermediate acting have half-life less than approximately 8 to 40 hours. Long acting half-life 40 to 250 hours. Example for short acting: midazolam, triazolam. Intermediate acting: lorazepam, temazepam. Long acting: diazepam, nitrazepam, etc. Mechanism of action of benzodiazepines. Benzodiazepines binds with specific regulatory site on GABA receptor in brain, enhance GABA activity, then opening of chloride channels, it increases the frequency of chloride influx, then hyperpolarization of cells, then depression of the CNS. Pharmacological action: benzodiazepines, CNS effect, anxiolytic, sedation and induction of sleep, muscle relaxation, anticonvulsant effect, andrograde amnesia, decreased dose of anesthetic. Peripheral action: it includes neuromuscular blockade in high doses, then coronary vasodilation if we prescribe in IV. Adverse effect. Adverse effect and choice. Benzodiazepines. Adverse effects. A. Normal dose. We have dry mouth, light headache, confusion, ataxia, impaired driving skill. In acute overdose, we have prolonged sleep, tolerance and dependency, decreased libido. Choice of choice of treatment for anxiety, diazepam, hypnotics, temazepam, anticonvulsants, lorazepam, antitetanus we can give diazepam, antidepressants we can give aprazolam. Sedative-Hypnotics, barbiturates. Classification: ultra short acting, acts within seconds, duration of action 30 minutes, main use IV anesthetics, example thiopentanal sodium. Short acting, duration of action 2 hours, main use sedative, example phenobarbital. Intermediate acting, duration of action 3 to 5 hours, main use hypnotic, example aminobarbital. Long acting, duration of action greater than 6 hours, main use anticonvulsant phenobarbital. Barbiturates, mechanism of action. Barbiturates binds with AMPA receptor, then leads to inhibition of AMPA receptor, inhibition of glutamate, it leads to depression of CNS. Or in another way, barbiturates binds with GABA receptor, activation of GABA receptor, opening of chloride channel, it leads to increased duration of GABA gated channels opening, then leads to hyperpolarization of cells, potentiate GABA inhibitory action. It leads to depression of CNS. Barbiturates, indications and adverse effect. Indications: anticonvulsants, sedative and hypnotics, IV anesthesia, hyperbilirubinemia, kernicterus, cholestasis. Adverse effect: drowsiness, overexcitement, nightmares and night terrors, weakness, allergic skin reaction, localized or diffuse pain, psychological dependence, then finally tolerance. Sedative hypnotics, newer drugs, anxiety and sleep disorder. We can give buspirone and analogs, ipsapirone, gepirone, tandospirone, solpidum, and zaleplone. CNS depressants, tranquilizers, produce calmness and quietness, reduce anxiety, tension and aggression, also called peace pill. Example: major phenothiazine derivatives, example chlorpromazine, promethazine, etc. Then reserpine, etc. Benzodiazepines, phenobarbital are minor. CNS depressants, anticonvulsant drugs, used to treat epileptic seizures, more accurately called anti-epileptic drugs. Example: carbamazepine, clonazepam, diazepam, divalproex, phenytoin. Anticonvulsant drugs, mechanism of action, principle: depolarization of nerve, convulsion, repolarization of nerve, returning to normal state. Blocking of Na plus channels, enhance GABA mediated synaptic inhibition, calcium 2 plus channel blockade. Analgesics, narcotic and non-narcotic. Then it helps to relieve pain, don't impair degree of consciousness. Narcotic versus non-narcotic analgesic. Narcotic, highly potent, addicting, but non-narcotic, less potent, less addicting. Narcotic depresses CNS, non-narcotic don't depress. Narcotic no AI and AP action, and non-narcotic have AI and AP action. Narcotic have low TA, that is therapeutic index, and non-narcotic have high therapeutic index. Opioid antagonist, example naloxone. Addicting drugs, morphine, heroin. Opioids, actions and mechanism of action. General action: analgesia, respiratory depression, constipation, urinary retention, cough suppression, emesis, meiosis, sedation, euphoria or dysphoria. Mechanism of action: stimulation of opioid receptors, mu delta kappa, then it leads to increased potassium efflux, reduce calcium 2 plus influx, and decrease calcium decrease cyclic AMP. It leads to inhibition of cell firing. It leads to elimination of pain. For CNS stimulants, we have directly acting on CNS and reflexively acting on CNS. Directly acting on CNS, we have cortical stimulants, medullary stimulants, spinal stimulants. Cortical stimulants, we have amphetamine, aminophylline. Medullary stimulants, example, picrotoxin, nicotinamide. Spinal stimulants, we have strychnine, brucine. Reflexively acting on CNS, we have nicotine, ammonia, etc. Progressive grade of CNS excitation: mild hyperexcitability, then severe hyperexcitability, then mild convulsion, then severe convulsion. These are the grade. When we prescribe these drugs, then if the drug in high doses, then it leads to excitation of CNS. It can be vary from mild to severe, then it leads to convulsion, then it leads to mild and severe convulsions. Miscellaneous: we can give levodopa and amantadine for Parkinsonism. We can give baclofen and tizanidine for multiple sclerosis. For Alzheimer's disease, we have donepezil and tacrine, etc. In myasthenia gravis, we have the drug azathioprine, and schizophrenia, we have psychotropic drugs. PNS pharmacology, that is peripheral nervous system pharmacology. Outside of the brain and the spinal cord, we have the peripheral nervous system, which include the ganglia, nerves, etc. And in peripheral nervous system, we have 12 pair of cranial nerves and 31 pair of spinal nerves. PNS, autonomic versus somatic. Autonomic, 2 neurons to supply smooth muscles and glands. Somatic, single neuron connect to CNS to skeletal muscle. Peripheral ganglia present. In somatic, peripheral ganglia absent. Synapses are entirely within CNS. In autonomic, preganglionic nerves are myelinated and postganglionic nerves are non-myelinated. In somatic, both nerves are myelinated. In autonomic, dissection of nerve, some level of spontaneous activity is shown. Somatic nervous system, dissection of nerve leads to paralysis and atrophy of skeletal muscles. Autonomic nervous system, acetylcholine and norepinephrine are the neurotransmitters, and acetylcholine can be present in ganglia and parasympathetic neuroeffector junctions. Norepinephrine can be seen in sympathetic neuroeffector junctions. In somatic nervous system, acetylcholine at neuroeffector junctions. ANS classification: 2 sets of neurons, afferent and efferent. Afferent send impulses to CNS for interpretation. Efferent receive impulses from brain and transmits from the spinal cord to effector organ cells. They have 2 branches, sympathetic nervous system and parasympathetic nervous system. Both have preganglionic nerve and a postsynaptic nerve. Preganglionic nerve connects CNS to ganglia. Postsynaptic nerve connects ganglia to organs. Ganglia, which means it contains nerve endings of preganglionic nerve fibers and cell bodies of postganglionic nerve fibers. Sympathetic versus parasympathetic nerves. Sympathetic nerve arises from thoracolumbar, that is T1 to L3 region of spinal cord. Parasympathetic arises from craniosacral 3, 7, 9, 10, S2, S4 region of CNS. In sympathetic, ganglia are near to CNS. Ratio of pre and post ganglionic fibers is generally 1:20 or more. So post ganglionic fibers are longer. In parasympathetic nervous system, ganglia all away from CNS, close to organs. Ratio is generally 1:1. So post-ganglionic fibers are shorter. Acetylcholine were present in ganglia, norepinephrine at neuroeffector junctions. Acetylcholine in parasympathetic nervous system present in both ganglia and neuroeffector junctions. In sympathetic nervous system, sympathetic activities increases in stress and emergencies. In parasympathetic nervous system, the activity predominates during rest. You can see the picture of autonomic nervous system. We have the peripheral nervous system. Then you can see the effects of the autonomic nervous system. You can see the eyes, the tongue, salivary glands, heart, then bronchial muscles, then liver and GIT, then kidneys, then testicles, then ureters. Okay, and we will discuss about the sympathetic and parasympathetic effects on these organs. In tissues like eye, sympathetic action is dilation of pupil, and for parasympathetic it's constriction of pupil. And first one, sympathetic, saliva reduction, dry mouth, and parasympathetic increased salivation. Sympathetic increases heart rate, in parasympathetic decrease heart rate. In sympathetic system, smooth muscle relaxation, parasympathetic smooth muscle contraction. Sympathetic constriction of arteries, parasympathetic dilation of arteries. Sympathetic system decreased motility and secretion of GIT or gastrointestinal tract. In parasympathetic system, increased motility and secretion. Sympathetic convert glycogen to glucose for the energy production. Parasympathetic stimulates secretion of bile. Sympathetic system, sphincter contraction and smooth muscle relaxation. Parasympathetic, sphincter relaxation and smooth muscle contraction. Sympathetic, decreased urine, and parasympathetic we have increased urine. Sympathetic system, contract the uterus. In parasympathetic, contract of the uterus. Both are same in cases. And also ANS, the Neuro-Humoral Transmission, principal neurotransmitters, sympathetic nerves, adrenergic, which include norepinephrine or noradrenaline. Parasympathetic nerves, cholinergic, acetylcholine. Preganglionic nerve endings of both sympathetic and parasympathetic in ganglia, that is acetylcholine. You can see the picture. In the sympathetic system, we have the norepinephrine and acetylcholine, which is released from both postganglionic nerve endings. ANS, sympathetic nerve system, adrenergic, neurotransmitters like norepinephrine, epinephrine, dopamine. The production of these neurotransmitters is from phenylalanine, which is an amino acid, which is then converted into another amino acid, that is tyrosine, by using an enzyme hydroxylase. Then it converts into dopa again by hydroxylase. Then by using decarboxylase, it converts into dopamine. Then it finally produces the norepinephrine or noradrenaline by using hydroxylase enzyme again. Then it converts into epinephrine. Then this epinephrine is stored in the seminal vesicle. Then when the action potential came, the influx of calcium 2 plus can occur. It leads to the fusion of somatic vesicle into the membrane of presynaptic neuron. It leads to the exocytosis of norepinephrine. So the epinephrine now is going to release into the synaptic cleft. Okay, the norepinephrine in the synaptic cleft is just bind to postsynaptic neuron receptors. Then further, what we can say, the further action potential generates. Drugs that mimics action of sympathetic nervous system is known as adrenergic drugs. Drugs that inhibit the action of sympathomimetics is called anti-adrenergic or sympatholytic drugs. SNS, adrenergic classification. Based on mechanism of action, we have three categories: direct acting, indirect acting, mixed acting. Direct acting, we have alpha agonist and beta agonist. Alpha agonist, non-selective, example norepinephrine, epinephrine. Beta agonist, non-selective, example isoproterenol. Selective, alpha 1 and alpha 2 agonist, example clonidine and phenylephrine. Selective, beta 1 and beta 2 agonist, dobutamine and salbutamol. Indirect acting, example amphetamine. Mixed acting, example ephedrine. SNS adrenergic receptors and action. Four types of adrenergic receptors in organ cells. These receptors are alpha 1, alpha 2, beta 1, beta 2. Alpha 1 present in the blood vessel, it leads to its constriction and it increases blood pressure, decreases GI motility, contracts urinary bladder sphincter, dilates pupil, contracts uterus. Alpha 2 inhibits release of norepinephrine, decrease blood pressure, decrease intestinal secretion. Beta 1 increase heart rate and force of contraction of heart, that is, it's a cardiac stimulant. Beta 2 relaxation of smooth muscle in bronchi, that is, it's a bronchodilator. Uterus peripheral blood vessel dilation, then it stimulates insulin secretion. Adrenergic drugs, clinical uses. Cardiovascular system, we have adrenaline for cardiac arrest. For heart block, we have isoproterenol. For cardiogenic shock, we have dopamine. For anaphylactic reaction, we have adrenaline. Miscellaneous include prolonged action of local anesthetic by vasoconstriction, we prescribe adrenaline. Bronchial asthma by bronchodilation, we prescribe salbutamol and adrenaline. Allergic rhinitis, we can prescribe adrenaline. For dilating pupil, we can prescribe ephedrine. Anti-adrenergic drugs, sympatholytic drugs. Classification: adrenergic neuron blockers, example methyl dopa, reserpine. Adrenergic receptor blockers, alpha and beta antagonists. Alpha antagonist, beta antagonist. Alpha antagonist, alpha 1, example prazosin, alpha 2, idazoxan. Non-selective, example talazolin. Beta 1, example beta 1 blocker, example atenolol. Beta 2 example beta 2 blocker, example butoxamine. Non-selective blocker, example propanolol. Adverse effect: hypotension, bradycardia, edema. ANS, parasympathetic nervous system, cholinergic. The neurotransmitter is acetylcholine. The acetyl coenzyme A formation, then acetyl coenzyme A binds with choline, then it leads to formation of acetylcholine. This acetylcholine is stored into the seminal vesicle, then action potential generation, it leads to the opening of calcium 2 plus channel in the presynaptic neuron. It leads to the influx of calcium 2 plus, then the fusion of synaptic vesicle which contain the acetylcholine with the presynaptic axonal membrane. Then it leads to exocytosis of acetylcholine. Then acetylcholine acts on the postsynaptic neuron receptor. Then it leads to further action potential generation and impulse transmission. Drugs that mimic action of parasympathetic nervous system is called cholinergic or parasympathomimetic drugs. Drugs inhibit action of parasympathomimetics is anticholinergic or parasympatholytic drugs. Parasympathetic nervous system. Cholinergic classification. Direct acting example acetylcholine, pilocarpine, arecholine. Indirect acting irreversible acetylcholine esterase agents. Acetylcholine esterase, this is an enzyme which helps to break down of acetylcholine in the synaptic cleft. So if we are able to block the acetylcholine esterase enzyme, so we can inhibit the degradation of acetylcholine. So there is availability of acetylcholine increases, which also promote the function of parasympathetic action. Irreversible acetylcholine esterase agent, example malathion, carbaryl, etc. Reversible acetylcholine agents, example physostigmine, neostigmine, etc. Cholinergic receptors and responses. Types. Muscarinic receptors include M1, M2, M3, M4, M5 and nicotinic receptors NM and NN. Muscarinic responses are vasodilation, decreased cardiac output, increased GI motility, tone and secretion of GIT, then relaxation of GI sphincters, sweating, contracts gallbladder, bronchoconstriction, causes urination, increased tone and motility of uterus, meiosis. Nicotinic responses include muscular fasciculations, paralysis, long-term action, release of adrenaline from adrenal medulla. It leads to increased blood pressure. Cholinergic drugs. Clinical uses. For myasthenia gravis, we can prescribe physostigmine, neostigmine. Glaucoma. To reduce intraocular pressure, we can prescribe physostigmine 0.5 to 1%. Ruminal impaction. Physostigmine 30 to 40 mg subcutaneous injection in cattle. To control ectoparasites, we can prescribe carbaryl trichlorphone. As antidote in atropine poisoning, physostigmine we can prescribe. Urinary retention, we can prescribe neostigmine. In snake bite, specifically or especially cobra bite, neostigmine plus atropine to prevent respiratory paralysis. Anticholinergic parasympatholytic drugs. Non-selective muscarinic receptor antagonist, example atropine, scopolamine. Selective muscarinic antagonist, example pyrazapine M1 antagonist. Clinical uses as spasmolytic, decrease hypermotility of GIT, decrease hypertonicity of uterus, urinary bladder, ureter, bronchioles. As pre-anesthetic atropine sulfate, peptic ulcer pyrazapine. To dilate pupil homotropin. In bronchial asthma ipratropium. In OPI carbamate and mushroom poisoning. As anti-Parkinsonism drug, as anti-emetic drug. Thank you friends. Thank you for all. And if you have any doubt, you can comment on section. If you like this video, you can click on the like button. And if you are not subscribed to our channel, please subscribe and share to your friends. Bye friends.